Yeah, so good evening, everyone. This is Rolandas once again from Megagen, and welcome to our Megagen second online education series, Minimizing Chair Time. Globally, dentistry is facing a new challenge, how to work safely and efficiently in this COVID-19 period. I think we will all agree that reducing chair time is an important factor, and this series will provide you with ideas, innovations, and reminders for doing exactly that. So to kick off the series, I'm very honored and pleased to welcome Dr. Bruno Leitão from Portugal, specialist in oral surgery and implantology, who will walk us through his surgical and prosthodontic-related tips for maximizing clinical results and minimizing chair time as well. So welcome, Dr. Bruno Leitão, and thank you for being here with us today.
Thank you so much, Rolandas, for the kind introduction. It's a true pleasure to be here with you, and a true pleasure to kick off the second round of webinars from Megagen. We have done some case discussions, me and a lot of other nights before, and it's a pleasure to be connected with all of you.
It's a pleasure for us as well. Also, as this event is live, we will collect all of your questions, all of the questions from the attendees. So do not hesitate, please write down all of the questions that you're interested in. And at the end of the session, Dr. Leitão will answer all of them, as I expect. So, Dr. Leitão, yeah, I will help you. So anyways, Dr. Leitão, let me hand you over, and the stage is yours.
Okay, thank you very much. Can I share my screen? I think it's not activated. I'm not able to share it, Rolandas. Okay, now it's on. Okay, thank you very much, Rolandas. My name is Bruno Leitão. I'm here to talk to you a little bit about surgical and prosthodontic tips, and most of this webinar is going to be really clinical and really things that we can all use in our daily work as implantologists in order to minimize the share time. And this time with COVID, I think it's quite important, but it has always been important to reduce share time for economic reasons and also for patient-related reasons. Who wants to spend a lot of time in a dentist's chair? I don't, that's for sure. So please be free to use my media contacts that you see here to contact me anytime, and if I'm able to help you, it will be my pleasure. So I come from Portugal. Once all of this has gone away, I invite you to come cities with a lot of history. You will be for sure very welcome here in Portugal, and contact me. Maybe we can even get together. So I spend a lot of time, most of my time is as a clinical in a private setting, in two private settings in the cities of Oporto and Viseu. I spend also a lot of time in the university, the Portuguese Catholic University, located here in Viseu, and here you see a lot of people that are really important to me, both fellow colleagues and professors that you'll see some of their work during this presentation, also some pre and post-grad students, and of course this incredible family we all had from MINEC that I also invite you to join if you can. I'm sure we can all learn a lot from each other. So the patients always come to us looking, as you can see on the left, and saying that they want everything ready for tomorrow. Like Freddie Mercury once said, I want it all and I want it now. But the truth is, it's not possible to do it for yesterday. So in order to satisfy our patients, we must adopt strategies to reduce share time and improve our output, our time output of works. In order to get to an image like we see on the right a few appointments later. So When Sean and Susan kindly asked me to start these webinar sessions, I started to think how we could save time while maximizing our results with predictability. How do I do it? And I started to systematize all my ideas, and I came to 3 important chapters that I'm going to approach today, starting with the planning, then the intra-op, and of course the prosthodontics. In planning, I think it is really important for us to ask ourselves, how many surgical phases do I really need for this patient? Can I do it in 1 stage, 2 stages? I have to do GBR, I don't. Should I do bone augmentation? Should I go for soft tissues? Should I go graftless? Can I go with guided surgery? Can I use guided implant placement like R2Gate? Can I use, or better, how many and where should I place my implants when I'm talking about a full arch surgery? And if I can go with immediate surgery. So all of these stages which should think ahead of our surgery. On the intra-op, I'm going to talk a little bit about surgical tips for avoiding failures and save time. And on the prosto, I'm going to show you how you can duplicate your full arch provisional, both in a conventional way and a more digital way. I'm going to show you also a strategy I use a lot when I need to leave my implant submerged, and also work that we are doing right now with individualized profilers for immediate implants. So let's go. On planning, my first tip for you is that patients want results. They do not want case reports. And on a case like this, with a severe bone atrophy on the posterior mandible, of course we could use East Van Urban techniques. Of course, we can go for Professor Curie's techniques, but sometimes we can go with easier approaches, because my second tip is related to this. You see, in this case, it is possible to place implants. And my second tip is related because does size really matter? And I'm talking about implants, okay? Does size really matter? In this case that you just saw before, we were able to solve it using short implants. And the truth is that papers show that short implants have outcomes that are similar and comparable to those of regular size implants. Here you can see Megagen 6.5 and 7.5 placed in the posterior mandible with beautiful soft tissue response, and the case finished with some zirconia crowns. So I think this is predictable, and it's easy for the patient, and it's fast. You don't have to do all the time big GBR, big bone augmentation. Sometimes it is possible to solve cases easily. And also in the upper jaw, this is a patient that came to me with this image on the panoramic. He had already placed some implants. You can see there were some problems with the implants with the adjacent tooth, but he had no problems, no clinical problems. He wanted to place implants here in the first quadrant. So this patient had a big car accident. He's paralyzed on one side. He cannot speak. He talks to us with text messages or emails, and he cannot open his mouth for a long period of time. So I thought that I could go, and supported by papers and science, I could go for short implants also in the posterior maxilla. Here we did some Summers approach on the sinus, a crestal approach, very easy, very fast, and also predictable, although a blind technique. And we went for the placement of short 6.5 any ridge, 3.5 core, and 7 millimeters wide in this type of bone in the posterior mandible. And you can see the 2-year follow-up. And you can also see that the crown to implant ratio is not favorable at all. It's at least 2 to 1. But also science showed us that when it comes to implants, crown to implant ratio is not that important. So this is predictable for me, and it's easy and it's fast, and it will save you a lot of time. Is share time with the patient, a lot of time, a lot of surgery time also, and a lot of problems. So consider using short implants. My third tip for you is that usually less is more. On a case like this, and this patient came to me with this smile, he was a happy guy, no doubt about that. But of course, when we look at the X-ray, we can see the smile. And we can see that this patient needs a full arch rehabilitation. That's what he wants. He wants a solution for his upper arch. Of course, he also needs a solution for his mandible, but for now, he only wanted to do the upper arch. So I started thinking what kind of options I have with this kind of patient. And this kind of patients come to me weekly. So of course, I can go for a conventional 6-implant placement, performing 2 sinus lifts and placing 4 more anterior. I can also go for this kind of option, using tuberosity or even pterygoid implants in the posterior and use 4 more anterior. Or I can go with this, all-on-4 technique. And also show a simple solution, like all-on-4 can have a great implant survival and implant success, and also good prosthetic outcomes. So in this case, we went exactly for all-on-4. And for that, you can see here the surgical pictures with the bone reduction. You could see the smile because this patient had a big gummy smile, the bone reduction, then placing the implants, respecting the maxillary sinus. And you can see an image with 4 guiding burrs and paralleling pins. And you can see checking the implants considering my tooth guide. And on the day of the surgery, so we can have almost every time we can promise our patients to have an immediate loading. You can see in this case, we were able to do immediately some tissue profiling. This upper image is of 2 weeks later of the surgery. This patient was a smoker, and you can see what smoke will do to your provisional. But the most important thing is getting this profiling done immediately, because this way the tissue will heal and you will have beautiful tissue to do a white-only all-on-4 zirconia bridge, as we did in this case. So this is the final result 3 months afterwards, and you can see this beautiful scalloping of the soft tissues, and this was all done by the provisional you just saw. We did not need to do much more. We could add a little bit to get our soft tissue profile a little bit better when we want, and we can go for a long-term provisional to do so. But in the end, we can get this kind of result easily. And you can see all the patient follow-up up to 2 years. I think he should be coming this month or so. I don't know, with COVID, we don't know now. But I think he's going to be coming pretty soon for the 3-year follow-up with 0 complications and a happy patient. For me, it is always a happy doctor. And you can see we were able to solve the gummy smile and give a natural look with 1 simple surgery and fast surgery. I'm going to show you a little bit more on the Prosthotips, how we can use our provisional for the final prosthetics. My 4th tip to you when planning is to consider to go guided, because it can save you a lot of time. Of course, we need to select our cases properly for guided surgery, but if we are able to do so, we will do the surgical bit a lot faster, that's for sure. And I'm going to show you 1 case with R2Gate. And this is the case. This patient came to me and he had a trauma a few years ago. I think it was a car accident. And when he came only for aesthetic reasons, because he was not happy about the tooth. And when we did the X-ray, we found out that this patient had a huge external resorption. And when we probed the buccal, we found out that there was no buccal wall. And when we extracted that teeth, you can see the immediate collapse of the soft tissues because there was no buccal wall. You can see the end of the socket here and absolutely no buccal wall. So in a case like this, should we save time going for immediate placement? Of course not. I'm going to address a paper that we should all read from Boozer and Shen's team about the timings of placement. But in this case, with a full loss of the buccal plate, it was not possible to save time here. But we decided to GBR the socket on the same day we extracted, and about 6 months later, we had this profile. And this profile is looking okay considering the initial situation. So we did our Cbct, and we could see that the bone defect was filled, and the soft tissues profile was not perfect, of course, but it was okay. And I decided to go with R2Gate because this is a fresh regeneration, and I have no need of open this flap if I can use such an easy tool as R2Gate. And so we just send our scan or our tray impression along with our Cbct to the R2Gate center, and they send us a file that we can check with the implant placement. You can see here the green is the GBR we performed here, and we accept the positioning of the implant. You can see everything green is hard tissue, the greener the harder, of course, and we can select our implant placement, a guided system, of course. And we received this back at the office 1 week later, a surgical guide and a provisional also, all ready to do our surgery. So the first thing is to check the seating of the guide. You can see in the windows the seating of this guide, and you can see the window for the implant, the drilling and the implant placement. I decided to open up a little bit of the flap because I wanted to keep this soft tissue. It is important. Otherwise, I would simply remove it by drilling it away, and I did not want that. So you can see some pictures with the X-ray, with the first drill and the second drill, just to make sure everything is okay. Of course it is. And we can go ahead and place our implant. It is really important that when you are seating the implant, you see this green on this window of the guide, and that this black line can goes all the way to both parts of the acrylic guide you see here, because this means that the implant connection is where it is supposed to be considering the provisional, okay? And the black means that when it comes to vertical placement, it is exactly where we address it on the planning. And here you can see a close-up of the implant immediately after placement. You can see the bone around it, and you can see the beautiful placement we achieved in 5 minutes. So this surgery, I think for sure the pictures took a lot more time than the surgery, okay? So it is one approach in a way that we can save time, we can be less invasive, and it's quite easy also for the patient because it's quite comfortable, and the post-op is really minimal when we consider the alternative option of opening. Also, we can, of course, maintain soft tissues better, and we can go for our here in the provisional installed and the X-ray confirmation, and 3 months later we are ready. We have a good profile, not perfect, but a good profile, and we can go for our final zirconia crown. Going guided does not mean always that we should place, or we are placing, implants in a guided way. There are many other options. This guy in the lower right, Tiago, is an amazing periodontologist that works with me both in university and in my private clinic. And besides being an amazing surgeon, is also a great tech guy. So with him and other colleagues in the university, we've been trying out this kind of things. It's not new, of course. Dr. Gans was one of the inventors of these systems. But using this kind of guide, we can save time and we can do our surgeries in a safer way. Here you can see a guide for a lateral sinus lift, avoiding our artery. So as soon as we sit our guide, after opening up the flap, it's quite easy to follow the guide and open our window, a big window in this case, to make our sinus lift. It's quite faster if we get the guide to fit beautifully, and a lot safer, no complications, or at least no unexpected complications. My fifth tip for you is, if you can, go for immediate implant. If you have a patient that needs to extract a tooth, you should always ask him if he wants to place an implant, if it is possible to place an implant. Because that way you'll save a lot of time, you'll keep a lot of tissue, and the patient will be happy because you'll simply take one out and place one in. And if you are able to do immediate loading or at least immediate aesthetics, even better. So go for immediate implant when possible. And on the bottom of this slide, you can see the reference of the paper I was telling you about from Boozer and Shen's team about timing of implant placement. So if it is possible, I advise you strongly to place it. Because this, what you see here, you see an incisor, you see a molar and the premolar over here, all with any ridge implants. And this is the kind of bone response, beautiful bone response we have with immediate implants. It's predictable. Just select your cases and do the procedure in a conventional, normal way. It's absolutely predictable. But even if you're not doing immediate implant placement, at least try and go for socket preservation. My group from the university and other colleagues from Germany, from Frankfurt, we sent this paper out recently, some months ago, a systematic review and meta-analysis about dental implant outcomes when it comes to grafted sockets, and they are superior to non-grafted sockets. So even if you're not placing the implant, remember that the patient maybe one day wants to place the implant. So ask him also if he wants to go for a socket preservation, and explain him that in the future, if he wants to place an implant, it will be easier and more predictable. On the intra-op part on the surgery time, we can also do things faster, more predictable, and easier. I'll give you some tips of what I do. Let's start by how I go through a full arch fast. Because full arch surgery is quite different from other surgeries. I'm not saying that it is harder, but it's different. So my sixth tip for you is that if you are not going guided, make sure you open and maximize your access. You will work much faster and much better because you can see everything. If you are not able to see everything, you will probably fail. And this is the kind of normal access we do for, in this case, both upper jaws. I could have placed a lower, but we'll see in the next slide some lower cases. But make sure that you can see everything. This kind of flaps, usually on the buccal, they go from one side to the other and have two vertical releasing incisions on the distal, all the way to the free gum. My next tip is when you are doing bone reduction, which is pretty common if you're doing full arch surgery, use a combination of a double articulated bone gouge, as you can see here on the left. Being double articulated means you don't have to do a lot of force. You can easily cut the bone and save it because you might need it. And then use a large burr just for final smoothing of the edges. I see a lot of guys, a lot of colleagues doing this using piezo. It gives you a beautiful picture, that's for sure. But it takes much longer than using a double gouge. And you can see here the beginning after extractions of the previous case and the bone reduction we did. My next tip, and going through the same case, is try, if it is possible, to select the same implant width. It will help you a lot, and if it's possible, also the length. Because if it is possible, it's much easier to do the drilling, because you can do everything with the same burr and then change the burr and do all the drillings. Another tip is do first the most mesial and then the most distal implant you are planning. Because if in this case I was planning 6 implants, if I do this first and this next, the most posterior, it's quite easy to see where is the middle. And same on the other side. Another tip, and using the same case, you can see the bone that we collected using the bone gouge filling all the sockets of the extracted teeth. Another tip is for you to install your intermediate abutments in surgery, even if you're not doing immediate loading. Of course, if you're doing, there is no doubt about it. Not because of the peri-implant marginal bone changes. You see on the lower article that me and my team from the university published a few months ago, comparing the influence of timing, of connection timing of intermediate abutments on the peri-implant marginal bone loss. And it's not significant. But what is for me important, it is that you're going to make everything when it comes to prosthodontics much easier, because you can get easily this kind of profile, and you do not have to reopen, and you have the beautiful access to your intermediate abutments. In this case, the straight octa abutments that I like these abutments for when I can use straight intermediates. And you can see the case in the beginning and in the end. You see that this case needed a big bone reduction. Of course, I presented this case on a case discussion of Megagen. You can also check it out on Megagen, the full case. It's much complete than I'm talking here. And you can see the final case with the big bone reduction and the implant placement. We were able to achieve the results that this lady wanted, to have a beautiful smile, feeling happy, feeling confident. That was exactly what she needed. So I'll now give you some tips using a lower full arch case. Surgical tips also. In this case, I planned all on 4-ish case, because I did not needed to tilt this posterior implant over there. So, and these tips, you can also use them, of course, on the upper arch. They're not for lower. So one tip is to mark your reference. When you are doing a full arch, it's incredibly important that you always know where the midline is. Of course, you can do it this way. You see, we extracted the tooth. We have a very bad ridge, a very irregular shaped ridge, and we can do our bone reduction. And now we are prepared to start for implant placement. And the first thing I do is to mark my midline, always checking my midline. Talking about reference, one other important thing, if you're doing lower all-on-4 surgery, is to expose the mental foramen or nerve when you are releasing your flap. You can use a pencil to mark the position. I prefer to use a round small round drill, because if you use a pencil, sometimes with the saline, it goes away. But if you do a small burr perforation like you see here and over there, you know that your mental nerve is right below it. So you don't have to keep the flap pushed away, and you are safe, and you can start marking and preparing your implant positioning. Of course, you can also use the all-on-4 guide, marking the midline, and you have paralleling markers for your implant placement. I used to like this a lot. Today, honestly, I usually go for a much simple with a pin, and we can do this kind of surgery with a pin only and exposing the mental nerves, of course. If you're doing on the upper jaw, you must know where the anterior wall of the sinus is. You can check with X-ray using your first drill, or you can open a small window and identify it, using your touch and doing a small elevation, even if you need to place an implant a little bit to the posterior. Another very important tip if you're planning to do immediate loading is make sure that you have your provisional almost ready and your technician is close and will be available for you. You can see here in this case, this is not the previous case. I'll show you afterwards the prosthodontic phase of that surgery. But in this case, I like to use this system. This is Easy Bar system, where these are prefabricated rods that you can link to your provisional abutments and then do a pickup. I usually do a pickup with the patient biting of my pre-ready provisional, and then my technician finishes the prosthetic for me. And you can see here the prosthetic, and you can see also the beautiful X-ray using this kind of prefabricated steel rods. And using these steel rods, I never had a fracture with provisionals, and it's quite frequent, unfortunately, to have fractures. Also, really important that your provisional does not have retentive sites. You should not be able to keep anything under. And this is the immediate result of the surgery we just saw with the provisional in place and the implants and the anti-ridge implants in place. With this kind of surgery and with this kind of implants, it's pretty hard not to get immediate loading conditions. That is one of the things that I love the most about both this technique and this implants. And at the end of the day, you get a beautiful smile from a very happy patient, and all you need is that smile to come home really happy. Another surgical clinical tip is to go for soft tissue at implant placement. If you need it, the patient is under local anesthesia, why not? It's one surgery only. And you can see how important it was in this case to correct. You can see this horizontal defect, but we had bone, so we did not need it. We don't need GBR, we don't need any bone. What we do need is soft tissue to correct this horizontal defect. And in this case, I went for a tuber, small free graft, and deepitalize it and stabilize it on the buccal. And you see the results after 1.5 years. And you can see that the horizontal defect is absolutely gone very easily, inexpensive, because this connective tissue graft is from the patient. He did not have to pay for it, and with beautiful and stable results. And this kind of free gingival grafts from tuber usually grow and mature a lot with time, and you can get beautiful results using this readily available material. One other thing that I think it is really important, because in clinic, share side, we have to deal with a lot of complication. And when it comes to implants, I guess that fractures of the prosthesis, especially in full arch, might be the most common mechanical complication, but biologically, perimplantitis can be a problem. Of course, we all know that. So my advice to you and my tip is don't postpone the treatment. You will lose time and money, and the patient will lose even more. And I'll show you what the patient will lose. So this patient came to me, as you can see here, with this redness, and she was bleeding a lot. There was separation coming from those two implants. And we decided to perform this technique. And this technique is quite dear to me, because this is my PhD subject, and this is implantoplasty. So with burrs, we can smoothen the surface of the implants, and we can detoxify that surface, and without any type of soft tissue or GBR. In this case, we were able to get these results in 2 months. Of course, this patient was an elderly patient and with a low smile. So it was not a problem to have metal showing. And you can see 8 months later, it's looking even better. It's looking really stable. And this is an option we can use when the lip line and the smile line favors it, and the patient accepts it. Because otherwise, if we do not do anything, and I'm not saying that this is the only option, of course, this is an aggressive option, but it has been shown to work really good. But if we do not do nothing, and we receive the patient every 4 or 6 months with some bleeding, some pus, some suppuration, some pain while touching, this is what we'll get. So in this case, this guy came with not a huge discomfort, but he had that discomfort for a lot of months. And when we did the X-ray, we thought, ouch, we have a real problem here. And you can see that probing, we can go all the way to the end of the implant. And trust me, if it looks bad on the X-ray, it's even worse when you open up a flap. And this is what you will get when you open a flap like this. Look at that enormous giant effect around the implant. Of course, this implant is lost and we have to remove it. And when we remove it and we eliminate all the soft granulation, inflammation tissue we have there, you get this socket. And you can see that there is even a palatal bone loss, full buccal bone loss, and you can see like the two threads of the implant where it was hanging on for its life. So of course, this is not a time to go for immediate implant placement. So we GBR the case, and you can see 8 months later how the GBR worked. It worked beautifully. We had a very nice horizontal plateau for implant placement. I want to say that this patient is a periodontal patient. This patient has chronic periodontitis. And 8 months after GBR, we can get a patient and we can start again, because this is truly starting again. And sometimes it is the best option and the most predictable and the fastest option to get everything back on its feet. And you can see we went now for a any ridge placement, a beautiful buccal bone, and we are able to get this patient with his tooth again. And in this case, I want to give you another tip. Make your incision wisely. Because if you go a little bit to the palatal or you use a roll flap while opening, you can get this beautiful horizontal correction. Can you see the difference between the soft tissue on the left, on the beginning, after GBR, and on the right, 3 months after implant placement? And this was done by simply placing our incision a little bit to the palatal and use a big healing abutment. And I love the healing abutments that we have with any ridge. I use them a lot for this kind of effect. And simply by doing that, we could correct our soft tissue profile. And 2 years follow-up, the patient is happy, I'm happy. Remember, he's a perio patient. He has problems, of course, but everything is looking stable in the implant. So now I want to talk to you a little bit about the prosthodontic tips. And this tip relates to full arch, because I find that in full arch surgery and prosthodontic phase, I think it is one of the steps where you lose more time, because you need to be in constant contact with your technician. You have to send everything to him. You have to wait that he gets it. So maybe we can save some time in these procedures. So this is exactly how I used to do my duplication of my full arch provisional. You see, at first, when the patient comes for like a 3-month period, first thing I do is take a silicone impression with a provisional screwed in mouth. And you can see here on the left. Be careful when you do this, because if there is retentions, you might get in trouble. Try to block that retentions ahead of doing your putty only tray impressions. And that will take you about 5 minutes. Then I would do a bite register with jet bite. Remember, the patient is still with a provisional screwed in place. And then I would take the opposing impression. This case was of a all-on-4 on the mandible only. Then I would unscrew the provisional from the mouth, screw my implant replicas in the prosthetics, and insert it in the silicone impression that I did in the beginning. I would insert this into here and then just apply my artificial gum. And doing this maybe 10 more minutes. And this is chair side, remember. Well, afterwards, you can pour the plaster on both trays, on this tray, and of course on the opposite, and wait for curing. At this stage, you might as well go and see another patient, because it's going to take you 40 minutes. That's for sure, for the plaster to cure. Afterwards, you get both models, and you articulate both models using the jet bite you've previously made. Now you can build a putty wall all around both buccal and inside and wait for curing. And finally, we can separate the models and unscrew the provisional from the model and screw it again in the patient's implants after, of course, a conventional splinted impression. Using this, because remember, this is going back to the patient's mouth, but using this model and this putty guide, the lab will know the current vertical dimension of occlusion, the teeth shape and position, all exactly the same as the provisional. If you are happy with the provisional, the lab, the technician, can use it and make it exactly as it is in the provisional. If there is something that you do not want, add some pictures, and it will be quite easy to communicate with your technician and do all the changes that you want. So this is the conventional, traditional way I do this kind of duplication of my full arch provisional. But my 16th tip for you is that we should all go tech, because I'm going to show you exactly the same thing, but now using scans. We can ask the patient to bite and scan the buccal profile. You can see it outside the mouth, so that it's easier for us to see. And you get the bite register by doing this. You can scan the provisionals, if there are two provisionals, outside the mouth. And you can send everything to the lab online with pictures. Now they have exactly the same information like we told before. You can see in this case, and I'm going to show you this case, it was a double full arch. You can see here the lower and here the upper. You can even see the calculus on the patient's provisional prosthetic work. Now he can print it and he can do everything he wants. And as you can see, we can get everything, all the information from the provisionals and start from there. We can do the changes because we have the pictures, we have this virtual models, and we can change everything. I do have a trust issue with a full arch scan for the passive fit of the structure. I don't know if you all have, but I do. I still do, when it comes to full arch, I still do a traditional splintered tray impression. But can you imagine the time we are saving by taking and addressing our provisionals that way? On the other option, it would take me almost 2 hours to get it done. By doing this, you can do it easily in 15 minutes or so, okay? These two guys work with me, Miguel and Gustavo. Miguel in the university is one of my oral surgery department colleagues, and his brother that has actually worked with me also in my private clinic, a great endodontist, and they helped me out with the videos. So this case that you just saw being scanned is this case. So we decided to, this patient had a failing dentition. We decided to go for full arch both in the maxilla and in the mandible. And this is how I usually do my immediate loading when I'm not doing all on 4. I usually do immediate loading only on the 4 most anterior implants, like you see here. I don't do any kind of cantilever while wearing a provisional, because a cantilever in the provisional is a fracture for sure. So try not to do it, because you'll have complications and you'll have the patient share side a lot more time. And you can see here the patient on the same day wearing the provisionals, and I'll show you the beginning and the follow-up. So about 3 months later, we did exactly what you saw there. We did a traditional work model, because we had also 6 implants, and the provisional were only on the 4th most anterior implant. So we did a conventional splinting tray impression, and we did the provisionals replication like you saw on the slides before. So this is on the try-in appointment. My technician can send me a PMMA proof that I can test and find out if it is looking good, and it is. And you see here, double full arch zirconia already installed, screwed in patient's mouth. And we can go from the initial situation that I'll show you to this final result, in this case with a double full arch monolithic zirconia, 12 piece on the upper and on the lower. And I did not even need to touch my PMMA proof. I can even leave it on the patient's mouth if I want to. I'll just spend a little bit more money on the interface for the zirconia. And you see, by doing this kind of immediate placement, this kind of duplication of the provisional, we were able to do this in 4 appointments, from the left to the right in 4 appointments. This patient had a provisional fracture, so he did a fix of the fracture while he was in Switzerland, and I was in India with Minek team. And it's interesting, and I decided to talk to you about this, because being in the Minek group is really good, because it was really easy to find a fellow colleague from Switzerland that was able to check my patient and treated him beautifully. And I'd like to thank him also for that. So, one more tip. I love this tip. If you are leaving an implant submerged for any reason, because it's not stable enough or whatever reason, take an impression after the implant placement anyhow. You can see here the scan bodies while the flap is still open. You can see the flap open here there was a big GBR on the buccal, and you can see the scan bodies. But why do I take this impression? It's because when I'm reopening this case, I already have my provisionals ready, and I can open, expose my implants, connect my provisional that was previously made with the ideal emergency profile and just do some slingshot suture around my provisional, and the soft tissue healing will be just perfect. And you have a solution for the patient because you are reopening and you already have the provisional ready. It's quite easy, it's quite time effective, and the patient will thank you because you will be able to give them a provisional really soon. And also the soft tissue healing phase will be already done when you go for impressions, because the provisional you designed, of course, will have the ideal profile. And you can see a case where I did that. I don't have the scan or the tray impressions with this upper central that we needed to GBR. This has been a failing implant, and we need to GBR. It was not perfect for immediate loading, but we took a tray, and when we reopened, we installed our provisional immediately that you see here. And a couple of months later, when we went for the final impressions to do our zirconia crown, this was the beautiful soft tissue we had. Beautiful soft tissue given by a provisional, pre-made provisional. And while being on that subject of provisionals and immediate implants, this a little back ago I talked to you about large healing abutments that I like. I love those those healing abutments. And you can see here an implant on a close friend of mine, an immediate implant on the second molar. And when we do this, we usually add a big gap. And of course, this is a cheap and reusable option using these really wide healing abutments that we have, because it can almost seal off our socket. And you can see the beautiful profile that we got simply from using a healing abutment that you can use again and again. But remember, this is not individualized. This is not a customized option. So it's good, yes, but it is not perfect. And using new technology, we can aim to perfect results, because we can do that, or we can also do that. This is Tiago, is the head of my team in the university, and we are about to release a paper on this, on customized healing abutments that are ready ahead of surgery. And we can use our scan and our Cbct to mimic the profile of the tooth that we are about to extract and have it ready. If it's guided, it can even come like this, already done. And you can see the beautiful soft tissue results we have using this customized healing abutments. And it is quite faster than doing it in the surgery, because of course you can install a temporary abutment, then use some flow composite all around it and take it out and place it on an implant replica and finish all the resin you place. That's an option. But how long do you take doing it beautifully? It takes a long time to get it really perfect. With this, we can do it not chair side. You're not spending time with a patient. You can have everything ready ahead of your surgery. And you can do like a Maryland, if you're not doing immediate loading, of course, this is the case. You can do a Maryland type provisional on top of this. Or you can do also this. This is other work we are doing in the university, along with my fellow prosthodontics team leader, André, and my periodontologist, I told you before, friend, Tiago. And in this case, it was a second molar, and you can see we could do the abutment design using Exocad, and we can install extracted teeth, install our temporary abutment, and then simply pick it up and quick finishing of the surface, and it's ready to be placed in mouth. You can see here the 2 months results, and you can see the beautiful soft tissue healing of this. And using scans before and after surgery, we can also do this. And we are doing a lot of research using this kind of overlapping of tissue profile to see dimensional changes on the surface. And you can see on the blue is the tissue where we lost some tissue. And on the green is the tissue that kept the same, and on the yellow is the tissue we have gained. So you see that we did not lose a lot of tissue, and the results are beautifully. We can do this, then we can customize our transfer and do our tray impression or our scan body impression and get amazing results. So this was the tips that I had for you when it comes to surgery and the prosthodontics. I have some take-home messages. I'll be happy to answer your questions afterwards. I did not want to make this bothering, so I did not want to make it too long, because I'm sure we are all at the end of our workday, and I really hope this has been helpful to you. So the first take-home message I would send to you is spend time planning. Planning is the most effective way to save time chairside. Understand if you can use tech, understand what you can do ahead of surgery, what you can have ready, like you saw with the provisionals or the customized abutments or the guides for guided surgery, whatever you can to save time with the patient. The patient will thank you. And also, really important, try and work with a multitasking team. Try to work with a lot of colleagues with different interests so that together you can do more. And finally, go tech, because I think that the main way to save time now, not in the future, because the future is now when it comes to this, is technology. So it's an investment we should all be ready to do. Otherwise, we'll be overlapped by our profession. So thank you very much. And I am here to answer your questions if you have.
Thank you, Dr. Leitão, for your really brilliant presentation. And I think all of your tips are going to work very well in the practice.
Thank you, Roland. Do you want me to stop sharing the image?
If you like yourself, so you can not stop.
Yeah, okay. This way you can see you.
So we didn't receive any questions, so either it was really clear or either nobody got the message, but I think all of the attendees really got the message, and everything.
I hope so. I tried to give some clinical tips, and some of these tips it took me, sometimes we go to like a 3-day course, a very tough 3-day course, and you come home with one small tip that will change your practice.
Yeah, it is true.
Kind of a collection of small tips that I think we can all learn from. Thank you very much. I'm seeing here some comments, and I thank you for your comments.
Oh, Bruno, it was excellent, interesting presentation. Luckily, my appointment didn't kick in, so here I am still.
Okay, that's good. We'd like to see you.
It was a good option. Good option. I wonder if you have had any problems with this COVID thing and incorporating any new techniques that you weren't doing before. Did you change much the way you are practicing?
I think that the main
the full body armor.
Yeah, the full body armor and the changes in schedules of the patients have been the main changes we have made. We are still doing pretty much what we were doing before, but we are of course thinking a lot about this subject, and that's why I found it so interesting that you propose this subject, because if we can save time and thinking about this COVID thing, we are putting ourselves and our patients in lesser risk. So I think that everything that can save share time, I think it's going to be in the near future. I think it's going to be really important. And I think that mostly the tech planning and the execution and using guided surgery, I think that is going to be really important in the future, because you can do surgeries quite fast, less invasively, and I think it's going to be better.
Yeah, I hope that this will become a direction that works better for everybody. You have 2 questions, I see, or 3, lots of.
Yes, sometimes I see more information about, it's Casper. Casper, my friend, how are you, from Denmark? I see more information around composite provisionals compared to titanium. Composite provisionals, okay. You're talking about individualized.
Yeah, you showed the case with the one.
Okay, customized with, well, of course that titanium is much more polished than it is a composite provisional. So that's I guess that's the main reason why you get more inflammation if you're using a resin. And also answering the second question is, if we can use composite, of course we can do it. It's I would say an old-fashioned but very practical way to do it. Just make sure that you polish it as good as you can and try to use some flowable resin, because it's better to achieve a high polishing finishing. Okay, I think it's also,
yeah,
Casper, if you are milling and not using a composite, the surface finishing is going to be much better.
Also, we have the third question. What is your opinion about on Artigate for full arch cases?
Of course, with full arch, you have to it's a little bit different, because you cannot use. Actually, you can. It depends, but you can use teeth and place some implants and only remove them on the finish. But to answer that question, I would say that for a full arch case, I like guided surgery if it is, I would say, a not so difficult case where I do not expect to do large GPR or large bone reductions. Although there are now options to do bone reductions with different sets of guides that you can use, one for the bone reduction and another for the implant placement. So I think it is a good option if you have a favorable case on full arch. I have to admit, I'm a little bit traditional when it comes to full arch, and I like to open and see what I'm doing, because that's the way I have been taught, and I like that approach, and I have good, beautiful results also, and I think that the beautiful results and the easy post-op come from a good provisional, honestly. But of course, if we have a full arch, we can do R2 using our pinholes and stabilizing our guide using using bone drilling and pinholes. There is a separate kit for
anchor kit.
Anchor kit, yes.
Yeah.
Yes. And the cases I have done of full arch with immediate surgery all went well, but they were also cases selected, and I selected them like for patients that are doing blood thinning medication, or that are favorable in terms of planning by the bone available and the lip positioning.
Yeah, so as I see, we don't have any more questions. Yeah,
I thank you for your comments.
Bruno, I think you will have a lot of attention. Normally we have an enormous amount of followers on the next day and later on the not live.
Yeah, of course.
So be prepared for some contact from that.
That's perfect. I invite you all to contact me through the channels that you saw in the presentation on the first and last slide. Feel free.
Contact Bruno immediately, right now.
Yes.
In the evening.
If I can help, I will help you out, that's for sure.
Also,
Bruno.
Yeah, and also, guys, the recorded video will be posted at midnight today. So if you skipped something, some kind of the part of the whole presentation, so you can catch up later. So thank you, Bruno, once again. That was really brilliant to listen to you. And
Pleasure.
Stay safe, stay healthy, and I hope to see you soon somewhere.
You too, my friends. It's been lovely to be with you. I enjoy a lot being with the Megagen family. A pleasure to see Sean. A pleasure to meet you also, Rolandas. And we talked a little bit on the last days. And I hope we can all get together in person soon. That is the main goal for all of us right now. Right?
This is our dream.
Yeah. I'm sure we'll be able to do it soon. I'm pretty sure.
All right. So thank you guys once more, and see you soon, and see you next time next week. Okay.
Bye bye.
All right, guys.
Thank you very much. Bye bye.
Okay.
Bye
Bye
bye.
bye. Bye bye.
Bye.